Disclosures, I consult for everybody, so I have no disclosures of conflicts. The title of what this presentation is, what is the role for chemotherapy, or I reworded it, is there a role for chemotherapy in CLL? The original goals of therapy are outlined on this slide. For younger patients, it used to be to get a deep remission, become MRD negative, get lots of efficacy, and you can withstand the toxicity. As patients get older, as organ function becomes reduced, as there are more comorbidities, it goes to regimens that are effective but less toxic and give you a good response with efficacy, but tolerability becomes more important. And in the older patient population, it was said that you should do no harm, palliate the patient, and regimens of low toxicity. Don't believe it. Old history. And when you look at a series of CALGB studies, as recently published by Jennifer Wyach, is there a pointer? Pointer. This thing points. There we go. These are some older studies with chlorambucil, with fludarabine, and panel A is under the age of 70, B is over 70, fludarabine, alemtuzumab, and finally we get to rituximab-based therapy, FR, and patients seem to do a bit better, but nothing is really terribly different in the older population, and none of these curves should get us excited that we were doing anything meaningful for our patients. One of the particularly bad subgroups of patients were those with 17p deletion. This is a study by Fisher from the German Hodgkin study group, event-free survival by cytogenetic subgroups. And I show this mainly for you to look at this curve, ingrain it into your brains, because we will be coming back to this more and more in the future, not only in my presentation, but in the other presentations. That is how poorly patients with 17p have done, a median less than a year. One important study that led us to the concept of chemoimmunotherapy for patients with CLL was the German CLL8 study. This was a randomization between FC and FCR, the primary endpoint being progression-free survival. And if you looked at progression-free survival and overall survival, they significantly favored the chemoimmunotherapy arm over the chemo alone. And you could predict how patients would do to some extent by their MRD status. If they had a CR or a PR that was MRD negative, their progression-free survival was better. If they were MRD positive and had a PR, they did the worst. And over here, it's not quite as clear. The first three categories, the CR and the PR, if you're MRD negative or the CR that's positive, did well. But those patients who are MRD positive and had a PR again do poorly with regard to survival. Nevertheless, none of these arms is particularly attractive. And then, about 55 years ago, bendamustine came along from this little college town in Jena, Germany, in the GDR, and in another study from Fisher, showed that the event-free survival and the overall survival appeared attractive for frontline bendamustine and rituximab. And this became widely adopted as a regimen not only in Germany, but in the United States and elsewhere. And this has left us with a little bit of a conundrum that I'll get to in a moment. When one looks at the various chemoimmunotherapy regimens that have been used extensively, the overall response rates in all the studies are about the same. They're 90 to 95%. There is a lot of variability in the complete response rate. But what I wanted to make a point on this slide is if you look at the CALGB study and you look at the German study, German studies, the patients tend to be a bit older. When you look at the FCR data from MD Anderson, not only are the patients younger, but fewer patients have an advanced stage. So one could say that if you treat patients with less likely of having an advanced stage and you treat patients who are younger, you're going to get better results. We need to be able to sort this out to better treat our patients. So now we better stratify patients by whether they are chemoimmunotherapy eligible, non-deletion 17p, chemotherapy, immunotherapy ineligible, non-17p, and patients with deletion 17p. So in this context, how do we decide between BR and FCR? On a level playing field was the CLL-10 trial. This was conducted in untreated, active CLL, no 17p, but good physical fitness, a direct head-to-head comparison of FCR and BR. And this was a study that made pretty much everybody happy. The FCR folks liked it, the BR folks liked it, and this is why. If you were younger and received FCR, or older, your outcome was about the same. But the older patients, FCR and BR, the curves were not statistically different for progression-free survival, although they were for the younger patients, the green curve and the purple curve. So if you're older, there was no difference in progression-free survival, but if you're younger, PFS favored FCR. However, when you look at overall survival, there is no difference between the regimens in either age category. More importantly, let's look at toxicity. FCR is associated with more neutropenia, thrombocytopenia, infections, secondary neoplasms, treatment-related mortality, although not significant, there is a trend. So it's a regimen in younger patients that has a longer progression-free survival with greater toxicity and no survival benefit. In older patients, bendamustine rituximab wins across the board. But an important observation has been made, and that is if you look at patients who are mutated. In panel B, for example, the mutated population does extremely well with FCR, and particularly in those patients, those 10% of patients, who also achieve a state of MRD negativity, about 80% of them seem to have long-term progression-free survival, and some have actually used the term cure in this patient group. I'm not sure to that point yet, but the long-term outcome is very good. And this has been substantiated in the CLL-8 trial. If you are mutated, you do very well with your FCR, certainly better than with FC alone. And in an Italian study, the same thing. If you are mutated, you do extremely well. But we know those patients do extremely well anyhow. If you look at patients who aren't fit, what do we do with those? Well, the CLL-11 trial informs us to some extent. This was a randomization between chlorambucil, obinutuzumab with chlorambucil, and rituximab with chlorambucil. The overall response rates were the same in the two combination arms and higher than the chlorambucil arm, but the CR rate seems to be higher with the obinutuzumab compared with rituximab. And if you look at MRD negativity, it certainly favored obinutuzumab versus rituximab in the bone marrow or in the blood. These curves show the progression-free survival with chlorambucil obinutuzumab versus chlorambucil alone, or the rituximab combination versus chlorambucil alone. This is the rituximab, and this is the obinutuzumab, and you can see in both settings, progression-free survival is superior to chlorambucil alone. If you look at overall survival, it doesn't quite make it in the rituximab arm, but it is significant in the obinutuzumab arm. So you're prolonging survival versus chlorambucil, which no one uses anyhow. If you look at the progression-free survival and overall survival comparing the two combination arms, obinutuzumab wins with regard to progression-free survival, and there is a strong trend in overall survival as well. So in this population, that appears to be a preferred combination if you happen to use chlorambucil. Chlorambucil is this kind of sick puppy that the FDA lets the pharmaceutical companies kick around and show that their drug is better than a 70-year-old pill. Be that as it may, if one looks at the RESONATE-2 trial, again versus chlorambucil, in older, mature patients, these are mature patients, they've been around a while, they're experienced, not old.
Old.
Hmm?
Old.
They're old? They're not old. Anyhow, this is a head-to-head comparison of ibrutinib versus chlorambucil in 65 years of age or older, treatment-naive patients with CLL. This is what you get. Get the same dreadful data with progression-free survival with chlorambucil, but here you've got something that looks better than one would see not only that compare with chlorambucil, but with most chemotherapy regimens. And the overall survival was also highly significantly longer than with chlorambucil alone. So here we have something that's not chemotherapy that's doing a whole lot better than chemotherapy in the frontline setting in older patients. I showed you the curves for 17p deleted CLL earlier. This is a study from John Bird, a longer follow-up of patients with high-risk disease, either it be 17p or 11q, treated with ibrutinib. This is the patients who didn't have either of the bad features. This is the 11q and the 17p. This is a combination of previously treated and untreated, but only 6% were previously untreated. So it's hard to interpret it. Fortunately, the group from the NIH recently published data looking at patients with 17p treated with ibrutinib, their survival, relapsed refractory, and particularly previously untreated. These are so much better than anything we have done with chemotherapy or chemoimmunotherapy in this patient population. So again, non-chemotherapy beats chemotherapy. So in untreated CLL, we have a number of studies that have been completed, such as the RESONATE-2 that I showed you. There's a pharmacyclic study of ibrutinib obinutuzumab versus chlorambucil obinutuzumab that we're waiting on. ECOG had ibrutinib rituximab versus FCR. The UK had a similar trial, and the Alliance ran a study of ibrutinib versus ibrutinib, rituximab versus BR in untreated patients, and I think this study has the possibility of totally changing how we treat patients with CLL, even though it was done in older patients. So to suggest the paradigm for previously untreated CLL requiring therapy, you look at age, comorbidities, functional status in FISH, but a clinical trial remains the preferred option. For those who are chemoimmunotherapy eligible, I think BR and FCR are both reasonable options. And certainly, ibrutinib remains an option for this patient population. For the chemoimmunotherapy ineligible, ibrutinib or chlorambucil obinutuzumab, I prefer ibrutinib. For the 17p, there is no question ibrutinib is the standard for frontline therapy. And for those who are frail, ibrutinib, or some might use an anti-CD20 as a single agent. It's not what I would recommend. But in the relapse refractory setting, you can repeat chemoimmunotherapy in patients who had a previously long remission. But the next remission is likely to be shorter. There is the potential for treatment-related malignant neoplasms and for cumulative toxicities such as myelotoxicity. If you just want to give them an anti-CD20, yeah, it's easy to do, but it's not going to produce much of a response. But the kinase inhibitor therapy have activity with mild to modest toxicity. Unfortunately, treatment is indefinite. Addressing an important issue, but probably not done in the right way, was the Helios trial. The Helios trial included, it was a phase 3 randomized placebo-controlled double-blind study, BR ibrutinib versus BR placebo. And the patients were well balanced in the two arms. The primary endpoint was progression-free survival, and you can see that the BR ibrutinib was so statistically better than the BR alone, with a hazard ratio of 0.2, so an 80% reduction in progression-free survival, and with a trend towards an overall survival benefit. But this is the kind of curve that you see with ibrutinib alone. So it's not really clear what the BR contributed to this. The better design would have been ibrutinib versus BR, and we would have answered probably a more clinically relevant question. Now, the RESONATE trial compared ibrutinib with ofatumumab, and you can see that this curve with the ibrutinib is similar to the BR ibrutinib I showed you on the previous curve, and ofatumumab, which pretty much nobody uses, it's like the chlorambucil for relapse patients. You had a hazard ratio here, again, of 0.2, highly significant progression-free survival. So again, non-chemotherapy, I was about to say trumps chemotherapy, and I probably shouldn't say that, in this study. And the overall survival, again, highly significant in the RESONATE study, favoring non-chemotherapy, in this case, versus an antibody. But there are other drugs out there which need to be mentioned because they are effective. Idelalisib, the PI3 kinase inhibitor. There was a study of rituximab idelalisib versus rituximab placebo with an extension tacked on. And what you found was adding the idelalisib to the rituximab gave you a significantly improved progression-free survival and overall survival. And these curves are at least as good as, if not better than one would see with chemotherapy in this context. And there are lots of other drugs. We'll be hearing more about venetoclax, for example, the BCL2 inhibitor, where in virtually every patient, the absolute lymphocyte count goes down, the nodal mass goes down, bone marrow infiltration goes down in relapsed refractory disease, and in patients without 17p, they do a bit better than those with 17p, but still, this curve with 17p is better than one would see with any chemotherapy regimen. There you go. Okay. If you look at relapsed refractory 17 patients, here's an overall survival and progression-free survival in a study by Stefan Stilgenbauer. Overall response rate of almost 80% in this particularly high-risk group of patients. So for previously treated CLL requiring therapy, again, you look at age, comorbidities, functional status in FISH, and a clinical trial is always preferred. For patients who had a long first response to chemoimmunotherapy, I would still use ibrutinib. In select patients are idelalisib. If they had a long response to the BR, you could consider that, or the same with FCR, but I don't see the point when the results with kinase inhibitors are at least as good as, if not better, than one would expect with chemoimmunotherapy in this context. With a short response, ibrutinib or idelalisib. For 17P, if you haven't had ibrutinib before, now's the time to get it. Venetoclax, definitely. And after that, perhaps R-idelalisib. And for the frail patients in this setting, ibrutinib, R-idelalisib, because this is the patient population for which it was approved. Patients with poor performance status, poor organ functioning, and unable to receive chemotherapy. Or perhaps my least favorite, an anti-CD20. So to conclude, our treatment approach to CLL is in evolution. Chemoimmunotherapy remains a reasonable initial option for those patients who are mutated. Because of the several studies I showed you where there's a prolonged progression-free survival, I predict this will change over time. The role of targeted approach is a subject of discussion and takes the most time in my clinic of any discussion I have. Should I get ibrutinib? Should I get chemoimmunotherapy? One needs to take into account patient age and comorbidities. The fact that with chemoimmunotherapy you are 6 and done versus indefinite therapy. There is cost and there is compliance that one needs to consider. I think there's little, if any, role for chemotherapy in relapsed refractory disease. Beyond venetoclax, we have acalabrutinib, we have TGR-1202, all of which are coming down the pike and may make an important contribution to this disease. But their role of these drugs is less clear in patients who have received ibrutinib as their initial therapy, but we are gaining more data in this context. But the bottom line is that with these new drugs, these new kinase inhibitors, pro-apoptotics, et cetera, and you'll hear more about the CAR T cells, I think the role for chemotherapy in CLL is vanishing, and a chemo-free world for CLL patients is a reality. Thank you.